So we are starting the recording now. Just gonna say hi to everyone. And I think the Shahd, are you with your team gonna present or?
No, I think we finished 2 weeks ago. I don't know.
Oh, sure. Sorry, this my I'm looking at the wrong date here. Let me just check here. So Hadil and the red team, I think they will be presenting today. So in the meantime, I'm just gonna ask if there is any questions in the meantime. We have a couple of minutes before we start. Go ahead, Dr. Mafaz. Go ahead.
Good evening, Doctor. How are you? How's everyone? Good evening. I had one small question. Sure. When we were writing the abstract, when we were presenting the results, we presented it. We wrote the percentage and everything, but then do we follow one simple or one format for the percentage? For example, if we say smokers had lung cancer with this percentage, or do we say that this percentage of smokers had lung cancer? Do we follow one format, or we can mix it up and because we're comparing pediatrics and geriatrics, that's why.
I think if you follow one format, that might be a good thing. Send me a draft, and we can look at what's the best.
Okay. Yes, thank you.
Thank you. Any other questions before we start?
Assalamu alaikum, everyone.
Alaikum assalam wa rahmah. How are you?
I'm good. How are you, Dr. Nader?
Very good. Thank you, Dr. Nader.
Thank you.
Hello,
so
everyone.
If the team, assalamu alaikum, Hadil. If your team is ready. Hello, everyone.
Yes.
Today we're gonna have our meeting, and just to make sure, say to you, Eid Mubarak. Next week we will not have the meeting because of the Eid. So happy Eid, inshallah, and we'll see you the week after. So without you, maybe Hadil, you can lead the team. Thank you.
Okay. Happy Eid, everyone. We're gonna start with sleep disorder with Dr. Dua and Dr. Muhtasim, inshallah. Okay. If you are ready, Dr. Dua, just share your screen with us.
Thank you, Dr. Hadil. Hello, everyone. This is Dr. Dua, and today I'm going to be presenting sleep disorders in the elderly, along with Dr. Mu'tasim. Let me just share my screen. Can everyone hear me well?
Yes.
Yeah, now we can see your screen.
Okay, good. So the objectives for today are going to be, we're going to be able to describe the age-related changes in sleep, the common psychiatric, medical, and neurologic causes of sleep problems in older adults, off-base and objective methods of evaluating sleep, and appropriate treatment of sleep problems in older adults. The topics that we'll be covering are the epidemiology of sleep disorders, the normal changes that happen in sleep with aging, evaluating sleep, common sleep problems, changes in sleep with dementia, sleep disturbances in the hospital, sleep in long-term care settings, and finally, management of insomnia. Starting off with the epidemiology of sleep disorders. In general, sleep disorders are common in older adults, particularly those with comorbid medical conditions and psychiatric illness. And that's why it's important to ask in the history if the patient has any chronic illness, because managing that problem can help managing the sleep disorder. The risk factors for sleep disturbances are chronic illness, multiple medical problems, mood disturbance, less physical activity, and or physical disability. The common primary sleep disorders that increase with age are sleep-related breathing disorders like sleep apnea, restless leg syndrome, and circadian rhythm sleep disorders. Also, insomnia is more common in women than men at all ages. And self-reported sleep difficulties are more common in older African Americans, particularly women and those with depression and other chronic illness. Studies also showed that 5% of older adults use prescription sedative hypnotics on a daily basis. And this is also an important point to ask in the history of the patient. Insomnia has been reported as a predictor of death in and nursing home placement in older adults. And also subjective sleep disturbance associated with worse health-related quality of life in older adults. Studies also showed that there's an association between worse sleep and subsequent cognitive decline in older adults. Here are the normal changes that happen in sleep with aging. As we all know, sleep is divided into stages. We have the non-REM sleep and the REM sleep. And the non-REM sleep is divided into stage N1, N2, and N3. And here are the normal changes that happen with aging, like total sleep time, it decreases with age. We have the sleep latency, which is the time to fall asleep. It increases or does not change with age. We have the sleep efficiency, which is time asleep over time in bed. It decreases with age. We also have time napping. It increases with age. We have stages N1 and N2. It increases with age. We have the sleep, the slow wave sleep, which is stage N3 of the non-REM sleep. It decreases with age. And we have the percentage of rapid eye movement. This decreases with age. And finally, waking up after sleep onset increases with age. So what do you do when the patient presents to you in the clinic? The important screening questions to ask is, if the patient, of course, is complaining about sleep, the important question to ask is, are you satisfied with your own sleep? Do you experience any fatigue during bedtime activity? And if they present with their bed partner, it's important to ask the bed partner as well, does the patient have any unusual behavior during sleep, like snoring, interrupted breathing, or leg movements? It's also important if the patient has a sleep log or a sleep diary, this can be really helpful. It has a questionnaire, many questions that can lead to the diagnosis. After completing the history, we do a focused physical exam guided by evidence from the history. And it's important to also do a mental status testing because we said sleep disorders are associated with other psychiatric disorders like depression or mood problems. And then after that, we do a lab testing guided by findings from the history and physical exam. The most important test in sleep disorders is polysomnography, but we don't always do a polysomnography. We do it only if it's indicated and if we suspect a primary sleep disorder like sleep apnea, narcolepsy, periodic limb movement disorder, violent or other unusual behaviors during sleep, other sleep symptoms that do not respond to treatment. We also have an in-home portable monitoring, which screens for sleep apnea. And we have the wrist activity monitor, which estimates sleep versus wakefulness. And this is helpful, especially in nursing home settings, to identify circadian rhythm sleep disorders. Moving on to insomnia, and the definition of insomnia by the DSM-5 is difficulty in initiating or maintaining sleep and waking up too early. It's associated with other symptoms like fatigue, poor concentration, daytime sleepiness, and concerns about sleep. We only call it insomnia if the symptoms present at least 3 times per week, and we call it chronic insomnia if symptoms are present for at least 3 months in a row. The common problems that are associated with insomnia are psychiatric problems like depression and anxiety, and of course, treating the depression can help treat the insomnia. Also, patients who don't have attention to their sleep complaints, this can impair their response to depression treatment. Studies also show that sleep difficulties are more common in caregiving individuals, and sleep disorders in older adults are also associated with increased suicidal risk. Here are the list of medical problems that are associated with insomnia, like arthritis, hypertension, heart disease, lung disease, stroke, neurodegenerative disorders, gastroesophageal reflux disease, nighttime urination, pain, paresthesia, cough, and nocturnal dyspnea. And the medications that can contribute to insomnia, particularly if taken near bedtime, are like diuretics because they interrupt sleep and the patient have to get up many times during the night to urinate. Also stimulating agents like caffeine, sympathomimetics, bronchodilators, and activating psychiatric medications. There are also some agents that can cause nightmares and impair sleep like antidepressants, anti-Parkinsonian agents, antihypertensives, and cholinesterase inhibitors. And here we should advise the patient if they're taking any stimulants, they should take it early in the morning. And if they're taking any sedatives, they should take it before bedtime. Chronic use of sedatives can cause fragmented sleep, light fragmented sleep, and the chronic use of sleep medications can lead to tolerance. Also, rebound insomnia can occur when chronic use of hypnotics is suddenly stopped. And there's also an association between alcohol and the lighter sleep of shorter durations. So all the patients tend to have consume alcohol before bedtime, thinking that it can initiate drowsiness, but we should advise them that this is not the case because later on it can impair sleep. Moving on to central sleep apnea, and in central sleep apnea, the respiratory effort is absent or decreased, and the cause is usually either the central nervous system or the cardiovascular system. It can also be a primary disorder or associated with neurodegenerative disorders like the neurodegenerative disorder of stroke or heart failure. Here also treating the underlying cause should be the focus. Obstructive sleep apnea is an obstruction in the airway resulting in continued breathing effort but inadequate ventilation. And to diagnose it, we should do a polysomnography or a portable home monitoring device. Patients usually complain of excessive daytime sleepiness, morning headache, personality changes, poor memory, confusion, and irritability. They also may be unaware of their trouble breathing at night. This is why it's important if they present you with their bed partner, or if you can ask their bed partner if the patient have loud snoring, or if they have cessation of breathing or choking sounds during sleep. Obstructive sleep apnea is associated with a high body mass index and large neck circumference, but this is not the case in older adults. Usually older adults present with normal body mass index and a normal neck circumference. Other predictors for obstructive sleep apnea is male gender. It's more common in males, and for falling asleep at inappropriate times or napping. This could be one of the signs. There's also a clue to diagnosis if the patient has treatment-resistant hypertension. And alcoholism has shown to be an important risk factor. There's also some evidence that shows an association between obstructive sleep apnea and dementia. Obstructive sleep apnea is a treatable condition that can be associated with cardiovascular disease, motor vehicle accidents. The patient can be driving and suddenly falls asleep, and cognitive impairment and all-cause mortality. To evaluate the patient, we should refer them to a sleep lab if indicated. And the main treatment for obstructive sleep apnea is the positive airway pressure. This reduces the sleepiness and improves quality of life. Older patients tend to tolerate just as well as younger patients. And it can also reduce blood pressure and cardiovascular disease in patients with similar issues. There's also an oral appliance which can be given to mild cases to adjust the jaw during sleep and relieve the obstruction, but only in mild cases. Moving on to periodically movements during sleep, which are repetitive stereotypic leg movements that occur during non-REM sleep, and its prevalence increases with age. Periodic limb movement disorders are associated with sleep complaints not explained by any other sleep disorder, and the diagnosis usually requires polysomnography. Moving on to restless leg syndrome, it's characterized by uncontrollable urge to move the legs, usually with unpleasant sensation in the legs that worsens with inactivity, generally at night, and improves with movement. It happens during awakening time, but it's one of the sleep disorders. The diagnosis is made clinically, and we don't need polysomnography here. Its prevalence increases with age. It does not only happen in the legs, it can also happen, it can also involve the arms. Many patients who have periodic limb movement system disorder can also have restless leg syndrome together. It's associated with medical problems like low ferritin level and anemia, and treating this iron deficiency anemia can treat restless leg syndrome. Can also can be aggravated or induced by medications like antiemetics, antipsychotics, SSRIs, tricyclic antidepressants, and diphenhydramine. This is why it's important to address these medications in the history. The treatment of restless leg syndrome, we only treat patients if it's impairing their quality of life. The treatment is a dopaminergic agent like pramipexole or ropinirole. They're usually used in older adults, and they decrease the symptoms of restless leg syndrome. But first, if they're taking any medications that's inducing it, we have to stop that medication. Also, we can use gabapentin off-label, but only in patients who cannot tolerate dopamine agonists. We can also use benzodiazepines on opioids, but not in older adults because of the side effects. Moving on to circadian rhythm sleeping disorders. This is a disturbance in circadian rhythm of the sleep-wake cycle that may be more common with advanced age, and it has types. First type is advanced sleep phase. Here, the patient falls asleep early and awakens early, and it's more common in older people. The second type is the delayed sleep phase. The patient here falls asleep late and awakens late. Also, there's irregular sleep-wake cycle, and here this is more common with dementia and nursing home residents. To establish the diagnosis, sleep logs and wrist actigraphy can be really helpful. We should refer the patient to a sleep specialist when symptoms do not respond to initial treatment. So what are the options of treatment for circadian rhythm sleep disorders? In advanced sleep phase, they may respond to evening exposure to bright light. And in the delayed sleep phase, patients may respond to morning exposure to bright light or evening melatonin. This is my last topic for now, for this presentation, and it's the REM sleep behavior disorder, which are excessive motor activities during sleep and a pathologic absence of the normal muscle atonia that occur during sleep. The presenting symptoms are usually vigorous sleep behaviors associated with bed dreams. The patient usually presents with their bed partner. Their bed partner tell you that the patient is having vigorous sleep behaviors, and he might injure himself or injure the bed partner. Studies showed that it may be familially predisposed, and it's also associated with other neurodegenerative disorders like Parkinson's disease or Lewy body dementia. Here we need polysomnography to establish the diagnosis. Also, if it's drug-induced, we should remove the offending agent, and we should make sure that the patient is sleeping in a safe environment, so he doesn't hurt himself or his bed partner. Some evidence supports that melatonin can be used in older patients with coexisting neurodegenerative disorders like Parkinson's or Lewy body dementia. Clonazepam can be used off-label sometimes in younger people, but not in older people because of the side effects. I'll stop here for now, and Dr. Muhtassim will continue from changes in sleep to dementia. Thank you, everyone.
Thank you, Dua. I hope everyone can hear me well. Hello. Hello.
Yes. Hello, Dr. Muhtassim. Go ahead. Yes.
Yes, you heard me. When I share my screen a little bit.
Yes, please.
give me a minute. I'm able to share my screen.
Not yet.
I share it right now. This appears to everyone.
Yes, now we can see.
Do you everybody see my screen?
For me,
Yes,
it's
Yes, we can.
Yes, we can see it.
Thank you. I would like to continue what's discussed today, as my colleague Dua said before. My topics, I will discuss change sleep with dementia and how to manage it, also sleep disturbance in a hospital setting and how to treat it, and sleep disturbance in the long-term facilities like nursery. And also I will give how to manage the insomnia in general, and with pharmacological and non-pharmacological intervention, including sleep hygiene and other area. And also we have 3 questions at the end of the presentation. Change sleep with dementia in all the patients. Dementia, sleep disturbances have many causes, and it may affect dementia as well. It may include more sleep disturbances and arousal, or decrease in sleep efficacy, or sometimes loss of deep sleep, or sleep fragmentation during the day and night. Disturbance of sleep-wake cycle is common in dementia. It includes excessive daytime sleeping and sometimes long time nighttime wakefulness. Many sleep problem in patients with dementia, it's sometimes challenging because the drug used for dementia may affect sleep. So if we use a cholinesterase inhibitor like nystamine and other drugs like memantidine, it may have cause vivid dreams. So it's better to use it in the morning. So if patient use it at night, it may disturb sleep also. Also, use of sedative and hypnotic agents had not been adequately tested in patients with dementia. Sometimes patients with dementia may have other diseases like SO. So if patient have an obstructive sleep apnea and positive airway pressure, it may help in treating post dementia and also improving the sleeping. Also, if the patient have a delayed or early sleep disturbances like advanced sleep cycle or delayed sleep cycles, daytime brightness may help and improve his sleep disturbances. Let us discuss the sleep disturbance in a hospital. There is many factors affecting insomnia in a hospital, including their illness itself, like if patient have dyspnea or pain or others. Also medication, some medication may cause the patient likes and psychoactive drugs. And also changing from usual nighttime routines that patient live in hospital or in home, then bring to hospital. This is changing may affect the sleep. And also sleep disruptive environment in a hospital, including doctor and nurse coming in and out and drugs at night. All this may affect sleep in patient hospital. And also whenever there is disturbances in sleep in hospital, this may increase a risk of patient delirium, develop delirium at hospital. Sleep disturbance in hospitals can be managed non-pharmacologically, as starting with daytime bright light illness, as patient in hospital cannot know which is the day or night. So open the window at early morning and just inform the patient of the time regularly. This may help the patient sleep well. Also, it's better to delay the medication till the patient later morning, not give the medication at the midnight or in this area. Also, there is sometimes a pack rub and warm drink relaxation tape at night may help in some patients. Use of this intervention may help decrease use of pharmacological treatment, which is may have implication in the patient condition and may affect the patient's disease. Also, use of this intervention may also improve quality of sleep. A medication for sleep disturbance in hospital is starting with a benzodiazepine receptor antagonist. It can be used, but in a small dose because it have many implications and side effects. Using of sedative antihistamine had not been used, or also because most of antihistamine and they have an anti-harm effect, which is may have anti-muscarinic effect, which is may affect may cause urine retention or increase delirium, or sometimes may cause constipation. Melatonin used, it sometimes can be used, but is till now is not an FDA approved. Medication for sleep disturbance in a hospital, as I told you, there is many comorbidity in the patient that admit to hospital. Like if the patient have sleep apnea at home and admit to hospital, it's better to continue on a positive airway pressure that patient use, or CPAP that use at home. This may help impose this condition and also the sleep. Especially patient going to surgery. So if the patient have an obstructive sleep apnea and have surgery, using of narcotic medications that it may precipitate or aggravate the condition. Let us discuss sleep in the long-term care setting. Cause of sleep difficulty in this area, like multiple physical illnesses, use of psychoactive medication like alcohol, caffeine, nicotine, and other drugs, and others norepinephrine inducing agents, disability and inactivity, large amount of time spent in bed during the daytime, increased prevalence of sleep disorders, also environmental factors such as the nighttime noise and light and disruptive in a nurse care facilities. Lack of exposure of bright light during the day also may causing of insomnia in such patient. Also, irregular sleep wake cycle is a common with the dozing and waking off and over 24 hours. Management of sleep in a long-term facility start with usually with a non-pharmacological intervention. Exposure start with exposure to the bright light during the daytime. Also, structural, physical, social activity during the daytime. A nighttime intervention to decrease the noise and light disruption. Management of insomnia in general. Usually we don't rush to the management unless we have an established diagnosis. We start with a history and examination. So if we find an physical or disease causing insomnia, better to treat the disease. And usually we don't rush to treatment. Either if the patient have a mild insomnia, they can be treated with a simple like sleep hygiene. We're gonna discuss it later. If the patient have a chronic insomnia, this intervention may not help. So we will proceed further like CBT for insomnia, or sometimes they use drugs. Patient should be educated also about the daytime napping, which if the patient taking on multiple daytime naps, it may affect his sleep and may cause an insomnia. A measure to improve sleep hygiene, we start with a maintain regular rising time, like going to sleep in a certain time and awaken in a certain times. Also get adequate exposure to bright light during the day, and maintain regular time unless it's too sleepy, or get up at the same time as discussed. Decrease or eliminate naps unless it's necessary. Exercise daily, but do not immediately before going to the bed. Usually we better avoid using bed for other activities like reading or eating or watching televisions, and relax mentally before going to sleep. Measure to improve sleep hygiene also, limit or eliminate alcohol, caffeine, nicotine, especially in the evening before bedtime. Wind down before bedtime, decrease in activity and other stuff that usually make patient more arousal before going to sleep, and maintain a routine period for preparation of bed. Control the nighttime environment with a comfortable cool temperature, quiet and darkness. Try a fan or other white noise machine. Wear comfortable clothing in the bed. If a patient was unable to go to sleep within 30 minutes, you better move out the beds and perform smoothing activities and then come back to sleep. Non-pharmacological intervention to improve sleep. We start with as we discussed, it's stimulus control. The goal of this stimulus control is recognition maladaptive sleep-related behavior. Usually, we advise patient not to go into bed, not use bed for other activities like eating or watching television. Also, if he was unable to sleep in the bed, it's better to move away from the bed. Also, another intervention is sleep restriction. Usually, this intervention we will take a sleep diary for 2 weeks and show which time the patient sleep or stay in the bed, or taking nap as a day. Then we take this the whole time of sleep and add 15 minutes per night. So if the patient should awaken a certain time and go to sleep at a certain time, and we increase the time after progression in treatment. The other intervention is a cognitive intervention, which is a cognitive therapy, which is try to treat a maladaptive behavior in a patient, like dysfunctional belief and attitude about sleep, or educate a patient of how the normal sleep change as discussed earlier, it is increased with age, and how patient can cope with it. And also to show the patient that if it's pathological, will not be treated by cognitive intervention. Relaxation techniques like biofeedback or muscle relaxation techniques sometimes may help in a patient with an anxiety. And it's treatment like meditation, like yoga and other relaxation technique. Also, bright lights intervention, and this had been shown. It had been adopted because, as we know, it's firstly started in treatment of seasonal depression. Then it had been shown to affect in the patient with insomnia, and it will be given accordingly. If the patient have a delayed sleep cycles, we will give him a bright light early morning. If the patient have an advanced sleep cycle, we'll give him bright light before going to bed. And we have, if the better to look for complications as it may affect cataract and others if the patient have eye problems. We discussed a cognitive behavioral therapy for insomnia, which is most effective. It is a combined approach. Generally, it combines sleep restriction, stimulus control. It is a multi-dimensional treatment, and we will discuss it in this slide. It's first treatment for chronic insomnia. It affects in older adults, and also effective patient have a comorbidity. As insomnia patient all usually have many comorbidities. It's generally provided by sleep medicine specialists like psychologists. Also, sometimes may have a self-help material online or using training associated with health profession. Sometimes we educate patient how to do an CBD. Let us discuss a medication we have for insomnia. Most sleep medication have an implication in elderly patient and usually restricted unless we have no other choice. Short-acting agents like benzodiazepine, it helps to initiate sleep, but it's have a rebound or withdrawal syndrome after discontinuation. Also, if we use a long-acting agent, it's may unaffected daytime, so patient will not able to get enough. The patient cannot have it continues sleeping even in the day, so it may complication related to driving or working or others. Using of sedative antipsychotic should not is not being recommended for older population. We discussed drugs used to treat medication for insomnia. It's include 4 groups. We first start with benzodiazepine, and the second group is non-benzodiazepine. We help patient. The third drugs it may use as it's like demoxibenzine. It's antidepressant treatment. Sometimes may help in insomnia, as a complication of it is sedation and sleeping. And also we can use melatonin receptors. And the last is oronoxy receptor blocker. Benzodiazepine, as we talked earlier, it's have a complication regarding it may affect a cognitive and psychomotor effect. Also may have an withdrawal symptoms, and usually avoiding in elderly population. And non-benzodiazepine like doliprane drugs and other zolpidem drugs, it's also have a side effect of benzodiazepine, increasing fall and unpleasant taste. Also, sometimes may have withdrawal symptoms. This is zolpidem. It's usually non-benzodiazepine also used. This also a non-benzodiazepine. Melatonin receptor agonist like ramimelatonin and tazamelatonine. It have no dependence effects and have no withdrawal symptoms, but may have some side effect like dizziness, myalgia, headaches, and sometimes rebound insomnia or withdrawal with discontinuation for the ramimelatonin. FDA approved for tazamelatonine. It's used if the patient was unable to sleep for 24 hours. Generally, melatonin drugs it's not FDA approved for elderly for treating insomnia in elderly population. Also, the last drugs we use, it's oronoxy receptor antagonist, and this had been adopted for treatment of narcolepsy. As patients who have narcolepsy, they usually have a depletion in oronoxy, so they use this drugs that is called sorivaxins, which is blocking oronoxy. And the complication of it is may cause next day stimulants, also impair performance, and may precipitate cataplexy in a patient. Others drugs has been used. It's antidepressant. As I told you, it's the use of side effects sometimes may help. So doxycycline is tricyclic antidepressant and have anti-harm effect. So it's also have complication regarding like constipation, deliriums, and may cause urine retention in elderly population. But the side effect of it is sedation. So we can use this side effect to help to improve insomnia. And the next drug is mirtazapine, which is an alpha-2 blocker, a serotonin receptor block, and it increases appetite, weight gain, and one of the side effects is a sedative, so use this as to treating of dementia, of insomnia, sorry. Also, other drugs is trazodone. It's sometimes used as this is also as antidepressant drugs. Use if patient have depression and insomnia, it may help because it causes sedation. It may have a complication regarding or side effect like orthostatic hypotension or beribism in a male population. Chronic hypnotic use, in most of studies, use of benzodiazepine, it's associated because the patient get elder, have sleep problems, so the benzodiazepine take increases age, and use in chronically may increase morbidity and mortality. Also may exacerbate sleep problems because it's withdrawal and affecting sleep in the day. To help if the patient is chronically use hypnotic use, we try to reduce it, but as we talk, it can affect, it have an withdrawal complication, so it's better to taper it down in a certain measure, like starting reducing a dose by half for 2 weeks prior full withdrawal. Also provide, in the meanwhile, we can provide a CBT management before we complete withdrawal of this medication from the patient. Non-prescription sleeping agent used by nearly a half of older adults, like melatonin, is insufficient evidence recommended treatment of chronic insomnia in older population, unless the other treatment is the patient was not responding to the other treatment. Other non-recommended treatment for treating insomnia, like sedative antihistamine, alcohol, or some herbal medicine, like one called valavalin and another called cava. The cava have a significant hepatotoxicity, and others its limit of effectiveness. They made a consequence from an internal medicine foundation. Don't use benzodiazepine or other sedative hypnotic in older patients at the first choice of insomnia. Usually try first sleep hygiene and non-pharmacological treatment. If the patient not improve, we'll go to other treatment accordingly. In summary, in older people, insomnia generally occur with a comorbidity with other psychiatric, medical, or neurological illnesses. CBT for insomnia is the first line treatment for chronic insomnia in all adult patients, including older population. And polysomnography is indicated if you have an insomnia with certain like primary sleep disorder suspected, or if the patient doesn't respond to treatment, we will do a polysomnography test to show which coding of insomnia. We're going to discuss the 3 quiz we have today. We're starting with the first case. It's an 80-year-old a woman come to the office because of 6 months history of difficulty staying asleep. She frequently napped during the day, and she is combined by her husband. Her nighttime awaking also affect her sleep and overall quality of life. She usually fall asleep easily around 9 to 10. And then wake up after 2 hours. She may get up to go to the bathroom and pattern of sleep for a few hours at the time, and continue until scheduled wake times at 6 a.m. She has at least 3 awaking during the night, which lasting between 30 to 1 hour. She sleeps after breakfast for 2 hours and takes 1 to 2 naps in the afternoon. She sometimes appears more agitated in the evening. She known case of moderate Alzheimer's disease. Which one of the following is the best treatment approach for this patient disorder? A, it's melatonin as scheduled bedtime, trazodone as scheduled bedtime, or CBT for insomnia, or bright light exposure during the day.
If I can answer that, Dr. Muhtasim.
Yes, go ahead.
Maybe we can choose bright light exposure because it showed that good with people with dementia.
I will reply to you. Let's the people answer first, then I will show the right answer and discuss it. So the right answer is D, as told, is bright light exposure during the daytime. It's not related to her condition, as I think it's mostly related to her sleep hygiene, as she is having a multiple daytime nap. So this is maybe the main problem of her indication for bright therapy for this patient. As she taking multiple naps, afternoon and in the after the third year, if you can go back a little bit. She have at least she sleep after breakfast for 2 hours, and also has take 1 to 2 naps in the afternoon. So because of that, the bright light therapy in the day is best for her the treatment, I think. The next case is a 75 years old man come to the office because of the past 2-year history of being bothered by excessive daytime sleepiness. He fell asleep at class in the theater and during the meeting. He noted his sleep is restlessness and no longer refreshing. His wife says that he snores lightly and sometimes she hears him gasping for air. Being a result of a sleep study, polysomnography done in other facilities, the total sleep time is 5.7 hours, and sleep architecture, all sleep stage recorded, reducing sleep with sleep is stage 3 even. Sleep efficacy, it's 78%. Apnea and hypopnea index obstructive 5.2 and central is 14.4. With China stock breeze better. Log C saturation up to 88. Have a history of heart failure with ejection fraction 38%. Which of the following is least likely to be beneficial of this patient? What do you think, Don?
B.
B, for me it's B.
Yes, B is the right answer. Because B, it is a new technique for many of an obstructive sleep apnea. It's then amazing because it uses an intelligence. So it's machine. It detects where the patient have hypoapnea and having apnea. So the machine will start. So it's the most effective machine right now, but it have a certain limitations. Like sometimes it doesn't help if the patient have a comorbidity illnesses. Like this patient, she besides having obstructive sleep, we have a reduced ejection fraction. So will not be the best treatment for him. But for other population, it's effective because I told you it is an intelligent type of machine that sometimes it detects. It's not work like a CBT. CBT, it's work all over the night till the patient is unplugged. But this adaptive serial ventilation, it's an adaptive technique according to it's individualized, and sometimes may work independently. So it helps by detecting low oxygen and other measures that use. But have some adverse effect in patient with heart failure, or patient have COPD also, or patient have restrictive thoracic or neuromuscular disease as a combined to his sleep apnea. This is the last case for today. It is a 76-year-old woman come to the office because she having a restless leg syndrome. Have worsened because she felt depressed since her husband was diagnosed with a multiple myeloma 4 months ago. The RLS, she has been controlled with the paramyxol 0.5 as a bedtime for the past 2 years. She has a history of RS depression previously resolved with myocardial therapy, and also she have a renal disease. Which of the following treatment least likely to increase the symptom of RLS in these patients? As Dr. Dua discussed earlier regarding the restless leg syndrome, and some medication may aggravate it. The first option is venlafaxine, and the second option is mirtazapine, and the third option is propabion, and the last option is paroxetine. So, guys, what do you think the least likely to maybe precipitate her restless syndrome?
Benzodiazepine should be like not used, so it's mirtazapine. I'm not sure.
Other? I will give you a hint. Most of drugs that precipitate restless syndrome, it is a serotonin-related effect. It's have sometimes it increases serotonin. Other serotonin, it have implication of so which of the following drugs have no effect on serotonin? It will be the best answer.
A.
No, venlafaxine, it is a non-serotonin and it is a serotonin reuptake inhibitor and dopamine reuptake inhibitor. So it increases serotonin. So it may aggravate the restless syndrome.
D.
No, not B. Also, mirtazapine, it's an alpha-2 receptors.
D for dog. I mean.
B or D? No, paroxetine is also SSRI. So it's SSRI and antiemetic and antipsychotics, all it aggravate restless syndrome. The best answer here it is bupropion. Bupropion it's an norepinephrine and dopamine reuptake inhibitor. So it has no effect for serotonin. And as I talked to you, serotonin it's implicated in the restless syndrome precipitation and aggregation. So the best answer here is C. And that is end for today. If you have any question, we will pray to help. Let's see what I need.
Thank you, Dr. Muhtasim and Dr. Dua, for this nice and informative presentation. If anyone has any question, please go ahead. Before we can go to the other presentation, which is polypharmacy in elderly, older adult with Dr. Sulafa and Dr. Rihan. If there is no question, we can go to the next presentation with Dr. Sulafa, polypharmacy and older adult.
Assalamu alaikum, everyone. Yes, I'm ready. Dr. Mu'tasim, would you stop sharing your screen?
Go ahead, Dr. Sulafa. Stop sharing my screen.
Yes, it's starting. Can you see the screen now or not yet?
We see your screen right now.
Okay, thank you. Assalamu alaikum, everyone. This is Sulafa Mahmoud. I'm going to present polypharmacy in geriatric population. So topic to be covered are challenges of geriatric pharmacotherapy, age-associated changes in pharmacodynamics and pharmacokinetics, optimizing prescribing, adverse drug events, drug and drug disease interactions, principle of prescribing for older adults, and non-adherence and role of pharmacists. Why geriatric pharmacotherapy is important? Because geriatric population is growing. People age 65 are 14% of US population now and buying 33 prescribed drugs. By 2040 the population will be 25% of the general population and will buy 50% of prescribed medications. Geriatric pharmacotherapy is challenging because more drugs are available each year. FDA and off-label interactions are expanding. Formularies change frequently. Scientific advances in understanding of drug-drug interaction and drug change from prescription to OTC, over-the-counter medication. Nutraceutical like herbal preparations, nutritional supplements are booming. Pharmacokinetics is the activity of the drug in the body over a period of time, including processes by which drugs are absorbed, distributed, localized in the tissue, and excreted. Age-associated changes with pharmacokinetics, absorption, distribution, metabolism, and elimination all are affected. Aging and absorption, amount of the absorbed drug or bioavailability is not changed, but the absorption may be slowed, so the peak serum concentration may be lower or delayed. Factors affect drug absorption, like route of administrations, drug, what is taken with the drug, and comorbid conditions. Okay, factors affect drug absorption, like divalent cations, example, calcium, magnesium, iron, can affect absorption of many fluoroquinolones like ciprofloxacin. Enteral feeding may interfere with absorption of some drugs like phenytoin, levothyroxine. Increased gastric pH may increase or decrease absorption of other drugs. Drugs that affect GI motility can affect absorption also. Here I have definition of volume distribution is a theoretical volume occupied by the total amount of the drug in the body relative to its plasma concentration. Drugs that have low volume of distribution usually confined to the to intravascular space or intravascular compartment. Those are large, charged, hydrophilic, or plasma protein bound medications. Medication with intermediate volume of distribution confined to extracellular fluid compartment and usually are small hydrophilic molecules. Large volume of distribution, like distributing to all tissues, including the fat. Those are small lipophilic molecules, especially if bound to tissue proteins. Effects of aging on volume distribution. Age-associated changes in body composition can alter drug distribution. Distribution refers to the location in the body a drug penetrates and the time required for the drug to reach those levels expressed as a volume distribution. Low body water, lower volume of distribution of hydrophilic drugs like ethanol and lithium. Low body lean body mass, lower volumes of distribution for drugs that bind to muscle, like digoxin. Increased fat stores lead to higher volume distribution of lipophilic drugs, example diazepam and trazodone. Low plasma proteins, like albumin, lead to higher percentage of the drug that unbound or active. Metabolism, the liver is the most common site of drug metabolism. Metabolic clearance of a drug by the liver may be reduced because aging decreases blood flow to the liver, the size and mass. Drug clearance is reduced for drugs subject to phase 1 pathway or reactions. Phase 1 and phase 2 metabolism. Those for lipophilic drugs. Phase 1 is cytochrome B450 dependent and include reduction, the process of reduction, oxidation, hydrolysis, and this pathway or phase 1 converts the drugs into slightly polar metabolites, active or inactive. Phase 2 is methylation, glucuronidation, acetylation, or sulfation that converts the drug to very polar metabolites, which are inactive and renally excreted. Polar means water soluble. Geriatric usually lose phase 1 first and keep phase 2. Phase 1 pathway, hydration, hydroxylation, oxidation, dealkalination, and reduction convert drugs to metabolites with lower, equal, or more pharmacologic effect than the parent compound. Phase 2 pathway convert drugs into inactive metabolites that do not accumulate. With few exceptions, drugs metabolized by phase 2 pathway are preferred for older patients because they are not affected by aging. Effects of aging and clinical implications are still being researched. Cytochrome B3A4 are involved in more than 50% of the drug on the market. In vivo age and gender-related reduction in the drug clearance have been found for cytochrome B3A4 substrates. Cytochrome B3A4 is induced by general inducers like rifampin, phenytoin, carbamazepine, and inhibited by macrolides, antibiotics, itraconazole, ketoconazole, and grapefruit juice. Cytochrome B2D6 is involved in the metabolism of 25 to 30% of the marketed medications associated with only minimal age-related changes. CYP2D6 is involved in the metabolism of many psychotropic drugs and can be inhibited by many agents. Some people are poor metabolizers, 10% of Caucasian. Poor metabolizers, more than 70, have serum concentration 8-fold those with poor metabolizer less than 40. Other factors that affect drug metabolism, age and gender, drugs like zolpidem, peak concentration and exposure area under the curve have been reported to be 44.6 and 40.4 greater in older women respectively, with only modest differences found between older and younger men. Hepatic congestion from heart failure reduces metabolism of warfarin. Smoking increases clearance of theophylline. Elimination. Half-life of the drug is the time for the serum concentration of the drug to be declined by 50%. Clearance is the volume of the serum from which the drug is removed per unit time, like liter per hour or mil per minute. Half-life equal 0.7 times volume with distribution divided by clearance. Clearance is the rate of elimination divided by plasma concentration of the drug. Renal clearance is the volume of the plasma from which the substrate is completely cleared in urine per unit time. And this is the equation of the clearance of substance X is urine concentration of substance X times the urine flow rate divided by the plasma concentration of substance X. Kidney function is critical for drug elimination. Most drug exits the body via the kidney through the urine. Reduced elimination lead to drug accumulation and toxicity. Aging and common geriatric disorders can impair kidney function. The effects of aging on kidney, aging decreased kidney size, decreased renal blood flow, decreased number of functioning nephrons, and decreased renal tubular secretion. The overall result is decreased kidney function. Creatinine has several limitations in the estimation of GFR because its formation is due to largely muscle metabolism. Differences in muscle, that means differences in muscle mass, like higher in bodybuilders and lower in older people and those with amputation, affect the amount of creatinine produced. So it depends on the muscle mass. Decreased lean body mass lead to lower creatinine production and decreased GFR. The result in older people, the serum creatinine stays in normal range. Mass can change in creatinine clearance because they have low body mass. Two ways to determine creatinine clearance. Measuring creatinine is time consuming, require 24-hour urine collection. 8 hours urine collection may be accurate but not widely accepted. Estimate, usually done with Crocroft Gold equation. Here's the equation. Depends on weight in kilograms, age, divided by 72 times stable serum creatinine and times 0.85 in females. So even gender can affect the equation. This formula should be used routinely as a simple mean to provide reliable approximation of the residual renal function in all patients with chronic kidney disease. In normal weight people, ideal body weight should be used. In overweight or obese individuals, adjusted body weight has been found to more accurately estimate creatinine clearance. Adjusted body weight can be calculated by adding 40% of the difference between the actual body weight and the ideal body weight. Limitation of Cockcroft-Gault equation. In patients without significant age-related decline in renal function, the equation underestimates creatinine clearance. On those with muscle mass reduced beyond the normal aging, the equation is overestimate creatinine clearance. And we have also equation, it's called modification of the diet in renal disease. It's another method to estimate GFR. Not validated in adults more than 70 years on the other ethnic groups other than white and Black Americans. Pharmacodynamics is the time course and intensity of the pharmacologic effect of the drug may change with aging. Example, benzo may cause more sedation and poorer psychomotor performance in older adults because of reduced renal clearance of the drug and result in higher plasma level. Also, older patients may experience longer pain relief with morphine. So we need to optimize prescribing medications, achieve balance between over and under prescribing.
Oh, there's a pencil. A pencil?
So sorry.
Okay, better. Let me find the pen for you.
So sorry, one of you guys have this mic on. Achieve balance between over and under prescribing of beneficial therapies. Use caution with potentially inappropriate medications. More than 30% of ambulatory older adults receive at least one potentially inappropriate medication. Nearly 4% of the office visit and 10% of the hospital admission result in prescriptions of medication classified as never or rarely appropriate. And under-prescribing can result from thinking that older adults do not benefit from the medication. Medication intended as primary or secondary prevention, aggressive treatment of chronic conditions. We have beer criteria. The American Geriatric Society updated beer criteria in 2019 and includes the same 5 main categories in 2015, which are potentially inappropriate medication in older adults, potentially inappropriate medications to avoid in older adults with certain conditions, medication to be used with considerable cautions in older adults, medication combinations that may lead to harmful interactions, and the 5th category is a list of medications that should be avoided or dosed differently for those with poor renal function. It intends to improve the drug selection and reduce exposure to a potentially inappropriate medication in older adults. Recommendations are evidence-based and in 5 categories: drug to avoid in patients with specific diseases or syndromes, drugs to use with caution, and selected drugs whose dose should be adjusted based on kidney function, and selected drug-drug interaction. Examples of overprescribed inappropriately used drugs like androgens or testosterones, anti-infective agents, anticholinergics, urinary and GI antispasmodic, antipsychotics, benzos, digoxins, dipyrimidol, H2 receptor antagonists, fecal softeners, insulin, non-steroidal anti-inflammatory drugs, proton pump inhibitor, sedating antihistamines, skeletal muscle relaxant, and TCA, and vitamins and minerals. Commonly under-prescribed drugs like ACE inhibitors for the patient with diabetes and proteinuria, angiotensin receptor blockers, anticoagulants, antihypertensive, and diuretics for uncontrolled hypertension, beta blockers for the patient after MI or heart failure, bronchodilators, PPIs for GI protection from non-steroidal anti-inflammatory drugs, vitamin D and calcium for the patient with or at risk of osteoporosis. Adverse drug events, it's an injury resulting from the use of a drug. Adverse drug reaction is the type of adverse drug events referring to harm directly caused by a drug or by a drug at usual doses. The most common type of adverse drug event was an unintentional overdose. Risk factors for adverse drug events, like when we use 9 or more medications, patient have 6 or more concurrent chronic conditions, 12 or more doses of the drugs per day, a prior adverse drug event, low body weight or low body mass index, age 85 or older, and estimated creatinine clearance less than 50 ml per minute. Adverse drug events are responsible for 5% to 28% of acute geriatric medical admissions. Incidence of adverse drug events in the hospitals are like 26 per 1,000 beds, which equal 2.6. In nursing homes, $1.33 is spent on adverse drug events for every $1 spent on medication. Adverse drug events rate 50.1 per 1,000 persons a year. Preventable adverse drug events rate is 13.8. Involved drugs are cardiovascular drugs, diuretics, non-steroidal, hypoglycemic agent, and anticoagulants. Most adverse drug events, like more than 95% of the drug events, are considered predictable. An adverse drug event prescribing cascade, like drug A or drug 1, lead to adverse drug effect, misinterpreted as a new medical condition, lead to use of drug 2, which can also lead to adverse drug event. Drug-drug interaction may lead to adverse drug events. Risk increases as the number of medication increases. Most common cardiovascular and psychotropic drugs. Key facts about drug-drug interactions. Some medication alter the absorption of other medication, like increasing, so the absorption may be increased or decreased. Use of the drugs with similar or opposite effects can result in exaggerated or decreased effects. Drug metabolism may be inhibited or induced. Most common adverse drug effects of drug interactions and neuropsychologic, primary delirium, lead to delirium, arterial hypertension, and acute kidney injury. Here we have examples for drugs when used in combination lead to adverse events, like AC inhibitors with potassium sparing diuretics lead to hyperkalemia, anticholinergic and anticholinergic lead to cognitive decline, calcium channel blockers with erythromycin or clarithromycin lead to hypertension and shock. So here we have also digoxin with erythromycin, clarithromycin, or azithromycin lead to digoxin toxicity. Lithium with loop diuretics or AC inhibitors lead to lithium toxicity. Combination of alpha blockers plus loop diuretics lead to urinary incontinence in women. Phenytoin and trimethoprim sulfamyxazole lead to phenytoin toxicity. Sulfonylurea and trimethoprim sulfamyxazole, ciprofloxacin, those are inhibitors. Cytochrome B450 inhibitors like ciprofloxacin, levofloxacin, erythromycin, clarithromycin, azithromycin, and sulflaxin lead to or augments the effect of sulfonylurea, lead to hypoglycemia. Tamoxifen and paroxetine and other cytochrome P2 D6 inhibitors lead to prevention of converting tamoxifen to its active metabolites, resulting in increased breast cancer-related deaths. Theophylline and ciprofloxacin lead to cephalin toxicity. Trimethoprim alone or with sulfamethoxazole and AC inhibitors or ARBs or spironolactone lead to hyperkalemia. Warfarin is trimethoprim, sulfamethoxazole, ciprofloxacin, levofloxacin, fluconazole, amoxicillin, cenfalexin, and amiodarone lead to bleeding. Also, use of warfarin and non-steroidal anti-inflammatory drugs lead to GI bleeding. Common drug disease interactions are like obesity, altered volume of distribution of lipophilic drugs. Ascites, altered volume of distribution of hydrophilic drugs. Dementia may increase sensitivity, induce paradoxical reactions to drugs with CNS or anticholinergic activity. Renal or hepatic impairment may also impair detoxification and excretion of drugs. Role of pharmacists. Pharmacists who are board certified in geriatric pharmacy carries the designation board certified geriatric pharmacist. Practice in variety of settings, including nursing homes, hospitals, community pharmacies, and private practices. Assist in designing appropriate medication regimen, including the choice of medication, dose, dosage form, and monitoring parameters. Also, pharmacists provide information on adverse drug events and drug interactions, assist adherence, and advise about cost issues. Principle of prescribing for older patients. The basics is start with a low dose, titrate upward slowly as tolerated by the patient, avoid starting 2 drugs at the same time. Before prescribing a new drug, we should consider is the drug medication necessary, what are the therapeutic endpoints, do the benefits outweigh the risk, is it used to treat effect of another drug, could one drug be used to treat 2 conditions, could it interact with the disease or other drug, does the patient know what it's for and how to take it, and what are the adverse drug events. At least annually, we should ask the patient to bring all medication prescribed OTC supplements to review. Medication reconciliation should occur at each transition of care. Ask about side effects and screen for drug and disease interactions. Look for duplicate therapies or pharmacologic effects. Eliminate unnecessary medication and simplify dosing regimen. Non-adherence may be as high as 50% among older patients. The predictors of non-adherence, like asymptomatic disease, if the patient has no symptoms, some patients believe that they do not need to use drugs for that condition. Inadequate follow-up, patient lack insight of value of treatment, missed appointment or transportation difficulties, low literacy, complicated dosing regimen also lead to non-adherence, and poor provider-patient relationship. Intervention to improve drug adherence, medication review and counseling to identify barriers, simplify regimen, and provide education. Telephone call reminders, reminder charts and calendars have been shown to be less effective. Interactive technology such as automated pill dispensers to supervise, remind, and monitor drug adherence. Its limited availability and also not undergone extensive scientific analysis. Involve a caregiver, also help with adherence, and utilize weekly pill boxes or blister packs. Do not prescribe medication without conducting a drug regimen review. In a summary, appropriate prescribing means choosing the correct dosage of the correct drug for the condition and individual patient. Age-altered pharmacokinetics like absorption, distribution, metabolism, and elimination. Adverse drug events are common but can be minimized with strict attention to the risk factors, drug-drug interaction, and drug-disease interaction. We have some cases. An 82-year-old woman comes to the office for her annual visit. She says that she is tired of taking so many medications and asks whether she can stop taking any. History: she has heart failure with reduced ejection fraction, ischemic heart disease, hyperlipidemia, hypertension, hypothyroidism, osteoporosis. Medications used: amlodipine, enalapril, furosemide, vitamin D, levothyroxine, metoprolol, extended release, and rosustatin. On examination, blood pressure is 112/70 when sitting and 109/65 when standing. Over the past 6 months, systolic blood pressure sitting has ranged from 105 to 113. Diastolic blood pressure has ranged from 68 to 72. Heart rate 72 beats per minute sitting and 74 on standing. Estimated creatinine clearance is 50 ml per minute. Which of the following medications can be safely discontinued at this time? Amlodipine, metoprolol, enalapril, furosemide. I can see like the answers. Should I go to answer the question? So the correct answer is amlodipine. Case number 2. 82-year-old woman is in the hospital because she had surgical repair of hip fracture 3 days ago. After she fell in the bathtub and at home, she is dizzy, and the nurse noted excessive daytime sedation. History: she has hypertension and osteoarthritis, hypercholesterolemia, and neuropathic pain. Baseline medication restarted 1 day after surgery. Lisinopril 20 mg, simvastatin 10, tramadol 200 mg, amlodipine 10 mg, gabapentin 600 twice daily, calcium carbonate 500 tablets 2 times daily. Additional medications since surgery: enoxaparin 30 mg twice daily, oxycodone 5 to 15 mg every 4 hours as needed. She has received 2 10 mg doses in the last 24 hours. Sorry. Ducosate 250 twice daily, omeprazole 20 mg, and steno 8.6. Examination: blood pressure 150/76. No orthostatic changes. Estimated creatinine clearance is 28 ml per minute. Blood sample drawn this morning. Estimated creatinine clearance 1 month ago was 50 ml per minute. She has ongoing kidney injury. Reduced clearance of which of the following drugs is most likely to cause her new symptoms? Gabapentin, oxycodone, omeprazole, or enoxaparin?
I think it's B, oxycodone.
Okay. We'll discuss that later. Everyone is answering. I can't see the answer, sorry. But the correct answer is gabapentin because it's renally excreted and the patient has like declining renal function 1 month ago was 50 ml per minute, and now it's 28 ml per minute. So mainly affect the drugs that's renally excreted like gabapentin. This one is the last case. 86-year-old man come to the ER because he is dizzy and has abdominal pain and black stool for 1 day. He lives alone. Family and neighbors check on him daily. He describes an episode of food poisoning 3 days ago with multiple bouts of vomiting and diarrhea. For the past 2 days, he has taken bismuth subsalicylate 2 to 3 times daily. He has history of anemia, atrial fibrillation, hypertension. The medication used dabigatran 150 orally twice daily for 2 years. Phenobarbital 10 for 20 years. Hydrochlorothiazide 12.5 orally for 20 years, and furosulfate 325 mg twice daily, and daily multivitamins. Examination, blood pressure is 110/68. Baseline was 148/82. Heart rate 104. Respiratory rate 18. Lab findings, hemoglobin 9, hematocrit 28%. Baseline was 36%. Platelet is 281. BUN is 28. Creatinine 1.9. Baseline was 1.4. Estimated creatinine clearance 22 ml per minute. Baseline was 58. Which of the following is the most likely cause of his presenting symptoms? Is it dabigatran overdose, drug interaction between dabigatran and bismuth subsalicylate, salicylate overdose from bismuth subsalicylate, or drug interaction between hydrochlorothiazide and bismuth subsalicylate? The answer is A, dabigatran overdose. 74-year-old woman is seen for follow-up 5 days after discharge from hospitalization for heart failure. She describes shortness of breath with moderate activity, history, coronary artery disease, hypertension, heart failure, atrial fibrillation, dyslipidemia, and osteoarthritis. Medication used, lisinopril 40, metoprolol 25, furosemide 40, digoxin 125, and aspirin 81. Atorvastatin 20, warfarin 3, acetaminophen 1000, 3 times daily, spironolactone 12.5, added at the hospital discharge, oral potassium chloride 20, also added at hospital discharge. Exam, blood pressure is 126/76 while sitting, and 128/78 while standing. Heart rate 77. Respiratory rate was 16. No signs of fluid overload. Weight is stable. Echocardiography from 1 year ago showed left ventricular hypertrophy, ejection fraction of 30%, and normal valvular function. Lab findings today and on the day of the hospital discharge. Sodium 136 and was 137. Potassium 4.4 and it was 4.2. MUN is 30 and was 29 milligram per deciliter. Serum creatinine is 1.6 and it was 1.5. Digoxin is 1.4. INR is 2.6. Which of the following is the best action to take? Discontinue spironolactone or discontinue potassium supplement. Decrease lisinopril to 30 milligram per deciliter or decrease digoxin to 125 every other day. And the answer is decrease reduction 125 every other day. Thank you so much. We can go to the next presenter.
Thank you so much, Dr. Slava, for the nice and very informative presentation, and thank you for the fellows for responding and answering the questions. Now we are going to present with Dr. Amna, SPSS, the demonstration of the t-test through SPSS application. If you are ready, Dr. Amna, you can go ahead. Thank you so much.
Hello, everyone. You hear me well?
Yes.
Okay. Okay, I'm gonna share from my phone because I have issue in my laptop. So forgive me for small writing, or the number may be not obvious to you all, but I will try to best.
No worries, Dr. Amna, you can go ahead.
Yes.
I said no worries, you can go ahead.
Okay. You see my screen, everyone?
Not yet.
Not yet. Okay. What about now?
No, not yet.
What I'm gonna do? Yes.
Yes, now
Yes.
we can see.
Yes. Sorry about that. Today I'm gonna talk about SPSS and the t-test. The t-test is easy to use in SPSS. We have like 3 types of t-test: one sample t-test, and 2 sample t-test, and paired sample t-test. So here in our example, we have the data shown below is the result obtained from 15% exam score from random sample of 20 students, and the description of variable is as follows. So we have common variable.
Like the screen is like black. Do you show?
Yeah, we can see.
We cannot see.
Yeah.
Okay. No, it's okay. If I move, you're gonna see my screen.
Oh, it is black.
You can try to send it in an email to your leader and they can open it for us.
Okay. Dr. Hadil, what's your email? Can you send it for me, please?
Of course. You will send it to WhatsApp. if anyone has any questions from the last presentation, you can go ahead till we can fix the technical problem. It's for Amma. Questions or additions?
You sent for me your email, Dr. Hadil?
You will send it through email or
Which one is better?
huh?
Which one is better for you? Did you send me your email?
Yes, it's better to be shared through email. I will just send you my email right now. You'll find it in your phone.
Okay.
Hello.
Yes.
Yes, I have thank you for the presentations for now, but I had a question for Dr. Salafa regarding the second case. It was mentioned that the patient had some decline in the renal clearance, but from the choices for the medications, it had enoxaparin, which is also, we shouldn't prescribe it to people with decreased renal function. So I wanted to know why we didn't choose that answer.
Victor
sorry. Yes, I'm here. You're asking about case number 2? Let me
yes.
Give me 1 second. Number 1. You said enoxaparin is a question about enoxaparin. Reduced clearance of which of the following drugs is most likely to cause her new symptoms?
Yes.
Yeah, the patient was sedated. The main presentation, I think, was sedation. She's 82 years old, in the hospital because she has surgical repair of the hip 3 days ago. After she fell, she is dizzy, and the nurse not excessive daytime sedation. So the accumulated drug is, they are asking exactly about what causing her symptoms. Reduced clearance of each of the following drugs is most likely cause of her new symptom. That's why they are talking about drugs that can cause sedation, which is gabapentin.
Okay, yeah, I think I misunderstood the question. That's why. Thank you.
Oh, yeah, it's okay. Thank you.
Thank you.
I'm still working to share that, but Dr. Hadil, can you check your WhatsApp, please?
Yes, I'm trying to download the.
Okay.
If you allow me, if anyone has SPSS application in his laptop, anyone of you?
I'm trying to download the free trial, but it's not working, so I'm go through the app that maybe is not able to continue the share. Like fixed example from Google.
I'm sorry, I'm not able to download the app. I don't know what's the problem, but I couldn't. You can try again. Maybe it will work this time.
Mm-hmm. Okay. Give me like 10 seconds to close it and open it again.
We can see it now.
Mm-hmm. Okay. Sorry, they make the ad now. Now you see.
No, not yet.
Okay, I can share a small video from
Yeah,
the
it's
YouTube. That
it's black screen. Maybe it's not
okay.
allowed to be shared.
Mm-hmm.
Okay. Do you want me to do that?
Yeah, you can go and then I
Okay.
try to make download for another example. Maybe it work. Let me stop that.
Okay, everyone, if you can hear me, you can see my screen.
No,
Yeah.
we can't see any screen sharing.
You can see it or no? Sorry.
No, it's like a picture and then it go away.
Oh, okay. Just a minute. Yeah, okay. So now you can see my screen.
Yes.
Yes.
Okay, this is like a small video that can show how we can do t-test through SPSS. I hope it will give us an idea.
So maybe I can jump in here. So for this demonstration, basically the SPSS has the data for two groups. Group 1, smokers, group 2, non-smokers. So let's say group 1, we identify with 0, and then group 2, we put number 1. So the first 10, 12, or 20 lines, these are the first group. And then if you scroll down, it will be the second group at the end of the list. So the first column, it has the data, the volume of the gray matter of the frontal lobe of the brain. So what they did MRI of the brain for all the sample, the control, and the smokers. So what they did, they calculate how much the volume for each patient. So first line, patient number 1 in group 1, and then number 2 is line number 2, the patient number 2, and so forth for participant number 2. So the idea is to compare group 1 versus group 2, or smokers versus not smokers. And the variable that we want to compare both group is the volume of the brain, the frontal lobe, the gray matter, or what they measured. You can click next or move the.
Okay.
Yeah. So this is the second group, and the first group is a 0. Yeah. So the control is 0 and the smokers is 1. So we go up to analyze, and then we click on mixed model on, or I think compare.
Yeah, compare mean.
Yeah. So yeah. So and then go to t-test. Yeah. If you want to take it from here, Anna, go ahead.
Yeah. So yeah, we choose independent sample t-test, and we want to like okay. Yeah, and then like comparing values, yeah, just one group. And we comparing, yeah, like smoker or non-smoker. Yeah, we defined group 1 as smokers, or 01, okay. And then we press continue. It's okay. But that.
Yeah, he just added the 2 groups.
Okay. Yeah, now the result is output is going like we have 2 tables. The table in the top is like the mean and standard deviation and standard error of the mean, which is descriptive analysis we talked before. And the second one is one interested about is independent sample t-test. So we have, yeah, another one. Yeah, it appears in a smoker and non-smoker group, and we want to compare that 2 groups together. So in independent sample t-test, the second table that we interest about today, it appears like we have the t value, which is marked by t, and the difference of the mean, which is n minus 1 is degree of freedom. So we want to, if we interpreted that the table, we look for three items. We look for the t value, and we look for the b value, and we see the confidence interval. So here in the t, like it appear in sorry, Dr. Hadil, I'm in the, yeah, I'm in the
I'm just
down.
following you, so
Yeah, because we talk about before, like the mean and standard deviation and standard error of the mean. But in the second one, we interest that our topic today is independent sample t-test. So we look to t value and the difference of means, and seek two tail, which is the b value, and the confidence interval. That how to interpret that table. So in t value, we look like a fixed table. It appear that table, it fixed table. We see the t value and compare that if it is greater or smaller than our sample. And the sig or TTL, which is a b value, like here is 0.004, or that mean is less than 0.05. That is significant. And the other one is the confidence interval. So if you can scroll to the right, please. Go to the right if you can, to show us our confidence interval.
you want me to activate his voice, maybe?
I want you to go to the right to see the confidence interval.
Just because he's like explaining, or like
Adil, if you click on, the X to close the window up, beside it there is a square to maximize the screen or the window, all the way up to the right corner.
Okay.
There is a square. Click on the square.
Right. More? No.
Not the X, the square beside the X, the red X, so that you can maximize the window.
I'm sorry to make it complicated for you all.
No, that's fine. So basically, Hadil, if you can click on the, I want you to maximize the window. So
maximize it. Okay.
Yeah, and instead of X, click on the box. Yeah, up by the X, the red X.
And in the top,
on the upper right, top
yeah.
right corner. Yeah, go up a little bit. Near the X, yes. Near the X, there is a square, and then the minus. Click on the square.
I don't think she's able to do this because she's sharing a video from YouTube.
Yeah, it's video. That's why.
Yeah, it's a video.
Okay. Oh, okay. So
yeah, and she cannot scroll to the right for you either.
Mm-hmm.
You will have to wait for the person to get to that point.
So this is the video. Okay, sorry.
So if we can interpret it from the b value. So we can, anyhow, guys, we can say that in general, and maybe if you see the video later, you can get the point. When we see table like this, we're gonna like look for 3 items again to know how our disease study is the measures of one group, like a smoker here, and the other one is non-smokers. And we want to see if the mean of that smokers and non-smoker is significantly different from the mean from each others. So two groups are measured in one time. because each group are independent, which of a smoker and one then is non-smokers. So that's why the name is independent, because they're not dependent on each others. So in the table, we look for 3 items for the T, which appear down like 3 point something, and the difference of the mean. This T value, we look at the fixed table and see if the T value is compare or smaller or greater than that or different. And the other one by C is like sick two-tailed, which is the B value. And the other one, which is not appear here, is a confidence interval, which is include 0 or no. So from here, we see that the B value is 0.04, is less than 0.05. So that we know that now the mean of a score of both smoker and non-smoker is equals. So this study is significant. Yeah, now it appears like the confidence interval, we have upper and lower. So we have both of them is positive, so it's not include 0. So that is statistically significant. And we know that from this study that the mean of the score of the mean score of smoker and non-smokers is equal. That's how I interpreted this study. This is one of the example of independent t-test. So if you found like another example for one sample or per t-test.
Another example for what? Sorry.
This like t-test, we have like 3 type: 1 sample t-test or 2 sample t-test or per t-test. Here they talking about independent sample t-test. So
if you want to sample t-test
from if you like, this video is number 7, so we maybe in number 6 or 5 we're gonna found another example. The same page we open it, the same video, but
the same video.
Yeah, instead of 7, video number 6, maybe it will work. Yeah. And try even to download in computer, which is broken, like I have half of the screen, but it didn't work.
You want to like continue explaining the same slide?
No, this is the same, right? This is the same, the independent t-test. I'm looking for 1 sample t-test or bare t-test to compare that data. Do you want me guys to present it in another day? It's better for you.
Maybe we can go over the other 2 tests and maybe some comparison between all of the 3 in a later date. So thank you so much, Dr. Anna, for this. I think this makes sense. So basically what we want to do is we want to compare 2 groups, and these 2 groups, they are not dependent on each other. The factors that some group smokes, the other don't smoke, so there is no relationship between both of them. It's not like in one patient, let's say patient smokes, and then we want to relate that to diabetes, for instance, or hypertension. So these might be related or dependent on each other, and because they are happening in one patient. So you cannot do the comparison independent t-test for them. But if you are comparing two groups, let's say international medical graduates versus US medical graduates. So these are two different groups. There is no relationship between them. Both of them take the test, then we will compare the result of the test, and then we'll see if there is a difference in the mean for the two groups. Same with smoking versus non-smoking, something like that. So you want to compare two groups, and then in these two groups, you want to see if there is a relationship. If there is one of the variable that is dependent or independent. If it's independent, then you want to use the independent t-test from SPSS or any other programs. And you want to see the difference. If the difference is 0. Let's say 0.4, 0.04, it's less than 0.05, then there is a significant difference. We say that's statistically different, or the difference is statistically significant between the two groups. So smoking affect the brain volume. If it's increasing, let's say, so we will say that a patient who smokes, their brain is increasing, or vice versa. If we found that their brain's volume is less compared to normal people, then we will say smoking affect the brain, and it will shrink that brain's lobe, or affected the size of the brain in that area. And this is significantly positive because we have the t-test that's positive. And the confidence intervals, if it's on one side, if it's on the positive side, that's significant, or if it's in the negative side, that's positive also. But if it has positive and negative, let's say it has one number, -1, 2, and then the other number is minus or plus 1, 3. So if the 0 is between these two numbers, then there is no confidence in your data. The difference between the two groups is not significant. Am I saying that right, Anne? Yeah.
Yes, you are right.
All right. Thank you so much. So any questions?
Sorry again for that.
Yeah. So if anyone has questions, please let us know. But I'd like to thank Dr. Dua Sulafa, Dr. Mu'tasim, and Dr. Hadid for all the hard work and the nice presentations, and Dr. Amna as well for the nice presentation. Sorry for the difficulty, the technical issue. So sometimes we face this trouble here and there. So don't worry about it. We'll hopefully in the future, we'll try to fix that.
Yeah, inshallah.
Inshallah. Thank you so much. So,
Thank you.
If no questions, we can go to the next section. I think we have a couple of minutes, but we might go over the 2-hour limit today. So
yeah, actually, we have 3 presentations. The first presentation, we can postpone it to the next meeting, the red team meeting. It's about, I think it was about appropriate conferences in geriatric. We want to apologize. We didn't prepare it yet. So if we can just postpone it to the next meeting, is that okay?
That's fine. That's fine. No worries about that. Okay. So let's talk about the project. If there is any ideas or any new projects or any questions about the current projects or updates, please jump ahead or raise your hand.
Hi, Dr. Nader, this is Shaima.
Hello, Shaima. Go ahead.
We're still working on the manuscript for the diagnostic modalities for capturing preclinical Alzheimer's disease. And meanwhile, as you advised me earlier, I prepared an abstract so we can start on publishing. publishing it like before the match season. And I sent you, emailed you a copy yesterday. If you can, please have a look and like help me make a better version of it, or discuss how we can proceed with submitting. Thank you very much.
Sounds good. I will do that. So I will look at it and send you an email.
I appreciate it.
Thank you. Thanks for the update. Anyone else? So we have a couple of projects are going on. If you have questions, let me know. The project leaders can email me, and then we can take or address the questions there. If there is other things that need clarification right away, you can call me or text me. I'll be happy to discuss over the phone again. If there is written like documents, you can share it via email. We can review and then talk about next. So in the coming days, I'll be in touch with you guys, and hopefully we will have a good meeting in 2 weeks. So if you have any questions, raise your hand. I'd like to thank the group, that the red team and the presenters. Thank you so much for great work. Okay, go ahead, Dr. Sarah Al-Shabia.
Yes, I just read, I think it's from last week or from the presentation skills, that there's going to be, Dr. Shema will be giving us a feedback. Is this for everyone or is this just for her group? It's written on the app on the main.
So the app, basically, I try to pair two. So if you have Dr. Shema on your app, that means she will give you feedback and then you can give her feedback. So when you are done with your video, can you share that link with her? And then when she is done with her, she can also share her video with you. So you can review her work and give her a feedback, see what's positive. You can tell her you did this good and what area she can improve on. Let's say she wants to raise up her voice or whatever you think is important. You can share that and she will give you a feedback. So does it make sense?
Yes, it does. Thank you.
You're welcome. Good question. Any other questions? So we had a very good meeting today. Thank you so much, and I wish you Eid Mubarak and happy Eid. We'll see you next, not this coming Saturday, the Saturday after. So I will update the app with the next meeting suggestion, and then the team and the leader for that team, they can check the app and then divide the task between you guys, if that's okay.
Okay, Dr. Nader. Thank you so much.
Thank you, Dr. Nader. Eid Mubarak.
Thank you so much, Dr. Nader.
Thank you, everyone.
Thank you, everyone.
Thank you. Thank you.
Thank you.
Eid Mubarak.
Thank you, everyone.
Eid Mubarak.
Thank you, Mubarak.
Thank you.